welcome and thank you to all involved with this very worthwhile project. Most specifically to my friends Dietmar Eickhoff and Faisal Mansour, who honored me with a request to deliver the keynote address for this program. The format will be simple. I'll do a short introduction as to how I became involved, what I've discovered in the 20+ years in which I've been working not only in Australia, but in the US and in many other countries around the world, with literally thousands of dentists, orthodontists, and other ists. I'll then discuss where the medical sleep industry is at today, what is projected for the future, and to explain how these projections, to my mind at least, will not make one jot of difference to the dismal outcomes currently being experienced. The reason for that bold and bleak statement is very simple. The problem is being addressed achterstevoor, ondersteboor. This is all going to be explained as we go along. So please feel free to pose questions, which I will attempt to answer at the end. I'll stop them into chat and the moderator will check them and go through them in the order in which they were received. So it's time to buckle up those seatbelts. And let's go on this roller coaster ride, which will probably turn a lot of your preconceived notions on their heads. So time for me to share my screen and pick up life as it is today in the beautiful city of Sydney, Australia. So this is going to be sunrise shortly over my balcony, heralding another beautiful day and a perfect summer's day in Sydney. And one of the most beautiful cities in the world. The topic is going to be centered around breathing disordered sleep. And breathing disordered sleep is just exactly what I say it is. It's a rapidly evolving connection between disrupted sleep and the sleep professional. So what we want to do here is, I didn't say the dentist, I didn't say the orthodontist, I didn't say the periodontist or the prosthodontist, because I'm referring to the dental profession as a profession, not as a group of clinical services. Because you guys are so experienced in so many other aspects of health and well-being. What you're doing is just a tip of the iceberg, and dentistry today, the dental profession today, is hopelessly, horribly, and terribly undervalued and underutilized. And as Ditz mentioned earlier, we have a pandemic here. This is far greater than COVID. This whole thing is just a total disaster. So it's wonderful to be back to the country in which I was born a very long time ago. It was a long time ago. And we're going to take it from here and discuss a number of things. Dentistry's Great Awakening, 2021. We're going to have a quick look at my journey, which has taken me 63 years since I graduated from Rhodes University in 1960. 60 years of experience in education and training and study in a lot of fields. There's a lot of stuff there in 60 odd years, I can tell you. But it's for a very good reason, because they're all linked. All of these things are interlinked. And that is why it's just been an evolution. I've also had the privilege and the honor to lecture for some of the probably largest leading training and education groups in the world. And I've got involved in an area called functionalism. I was honored in 2016 to be presented with a Lifetime Award for the contributions towards functionalism. So, of course, the content of this keynote address is purely for information and educational purposes. The information contained comes from reputable and reliable sources and does not advocate any modality or treatment. In the absence of valid clinical trials, evidence-based medicine is used to provide explanations. So first and foremost, what is a keynote address? It's an address designed to present the issues of primary interest to an assembly, and often to arouse unity and enthusiasm. I think it's very important for us to note this unity and enthusiasm, because sadly, there are many divisions in the world of medicine and dentistry, and that doesn't do anybody any favors, most particularly our patients. So I have a dream, and I say it softly and quite quickly because it didn't do Martin Luther King much good. And the dream is to create a new specialty. This is a specialty for dentists and orthodontists and prosthodontists and periodontists and pedodontists, which will fill the current void left by the lack of knowledge and education in that vital field of human behavior, which is the driver of dysfunction. And there'll be more about this as we go along. So I'm just going to switch camera here to make it a little more comfortable. Just 1 second. Okay. Keynote lectures don't teach anything. That's not their role. They provide a framework for what is to come so that you know in advance what to expect. Keynote speakers are usually very old and very gray with lots of hair and beard and very, very wise. I think the only category that I feel here is being very old. And this is what a keynote used to be like. Oh, machtig, those were the days, I can tell you. 500 dentists from all over the world. This is the Coyce Education Center in Seattle, in the United States. 5 days of the most incredible interaction. And who knows if these days will ever come back again. So this is what keynote is today, and we're separated by distance, but certainly not by passion. And when COVID is up, I tell you, I'm going to be on the first plane back to South Africa to come and meet as many of you as possible. This has been a fascinating journey. It started in Australia and has taken me literally all over the world. The United States, coast to coast and in the middle, the whole of Canada, the northern wilds of Canada, where it's so cold in the morning you find a dog stuck to the tree. It's taken me to Europe, to Italy, Spain, Portugal, France, Hungary, Czech Republic, into Russia, into Armenia, into Ukraine, to places like Cuba and the Caribbean and Mexico and Central America and South America. And of course, South Africa. And this is how it all began. So in 1999, I was teaching asthmatics using the Buteyko principles here in Australia. And I met a guy called John Flutter in Queensland. He was working almost exclusively with children. And he asked me whether I thought that there was a connection between breathing and malocclusion. Well, that kind of sparked an interest for one simple reason. It sounded a little far-fetched. But in the dim, distant past, I had personal experience. I had brought up a blended family of 5 children, 4 of whom who needed orthodontics. Incidentally, the 4 with problems were all C-section. I had no knowledge or interest in this in the 70s and 80s. I was told teeth grow crooked and need to be straightened, which is what we did. And believe me, there were some crooked teeth that needed some straightening. It was a long, drawn-out, expensive process. 10 years with multiple lost retainers and 1 silver Rolls Royce later, the orthodontist informed me the job was done. But it was not that simple. All 4 of them have suffered relapses and have airway issues of varying kinds, to varying degrees of severity. And they are all now in their late 40s, early 50s. I am not saying that the orthodontist caused the airway problem. Please, let me be very, very clear about this. These children were all compromised when I took them to see him. But what he did not help. In fact, he made it worse. Unwittingly, unknowingly, following best practice guidelines, he actually made it worse. And remember what he said. You remember, firstly, do no harm, Hippocrates. So he was not guilty, but it doesn't mean he was innocent. And the percentage of people today who have these sleep-related breathing disorders and this disrupted sleep issue, the percentage of those people who have had inappropriate teeth removed and bimax extrusion and retraction orthodontics and headgear and that percentage is extremely high. So the important thing here is that the more I dug into my 40-year-old anatomy and physiology books, the answer literally jumped out at me. It was one of those eureka moments where I realized this has nothing to do with sleep. It's all about interrupted breathing. And at the same time, the father of one of the kids we were working with mentioned that he was using a CPAP machine. And that was impossible to get used to it. It was literally killing him. He said his AHI was only 6, but the doctor told him he needed it. He was a chronic mouth breather with dry, cracked lips. And it was then that I made the connection between the mouth breathing, the low CO2, and central apnea, something that many, many in the medical profession today still do not understand. And that is another topic which we will talk about at another time. So the net widened, and I met John and Mike Mew. This is going back 20 years, and we have become close and very dear friends. At the same time, Patrick McKeon in Ireland became quite interested in what was going on in the dental sleep field, and he wrote a book, Buteyko Meets Dr. Mew, and the rest is history. Then in 2008, I brought Sandra Coulson out to Sydney to run the first ever orofacial myology training course in Australia. And this was held in my clinic in Sydney. And gee, guess who was there in all his sartorial glory? Is again John Flutter, one of the very first Australian dentists to become an orofacial myologist. Sarah Hornsby, whom you'll be meeting and hearing from later on, was another one of the trainees, and she went and upped her skills enormously. Then I met Steve Olmos right about the same time in 2008. And then when I moved to the United States, we had a number of interactions. And I presented at several of his meetings across the country. And you will get to meet Steve as well. And he is a firm believer that breathing is the driver rather than sleep. And he is a very generous guy, and I consult for 2 of his Sydney-based clinics on a regular basis. And he very kindly wrote this. He said, I thoroughly enjoyed your demystifying the airway course. You are a wonderful instructor. Gee, guys, that coming from Steve Olmos is praise indeed, I can tell you. I will share your website courses with my centers and at my courses. I really like what you've done. Best wishes, Stephen. Now we come to the South African link. Through John Flutter, I met Dietmar in Brisbane when he was visiting Australia back in 2008. He then returned and came to spend 10 days with me in Sydney on Bondi Beach. I want to tell you, he didn't look in the room much. He was looking outside at the bikinis on the beach. And then in 2010, I visited South Africa and we toured the country together, educating groups of dentists. I came back again in 2019 when I met Fazel. So that kind of wraps up the circuit. So what is the goal? If you don't know where you're going, you'll never know when you get there. The goal is maximum outcome with minimum intervention. We want to create something which is totally foreign to the disease management model of the Western world. We want a concerted, interdisciplinary approach to complex conditions, where the symptoms are not the sole focus, and where equal attention is paid to the cause, not just the intervention. So ask a person what the problem is, and they're going to tell you their symptoms. Symptoms are rarely the same as the problems that cause them. Okay, if you've got a compound fracture of the arm and you say, my arm is sore, the symptoms and, and the problem are the same. But what happens when you have subtleties? What happens if there are things that you don't know that you don't know? Very often the person who is treating the symptoms is not sufficiently qualified or educated to isolate and address the actual problem. This is an orofacial muscular problem, which has developed into an occlusal problem, which perpetuates the orofacial problem. So we have to bear all of these things in mind. So to find out more, we have to ask 5 critical questions. I call them the 5 WH questions. The key one, of course, is what is the problem? Not what are the symptoms? Why did it happen? Not just accepting that it happened. I'd had the orthodontist tell me, teeth grow crooked, and I accepted it, no more. When did it happen? Is it recent? Or is it of long duration? Where do we start in order to address the etiology? And guys, this is so important. Who is the appropriate practitioner to address the prime issue? Not necessarily the symptoms. Only then can we look at the how. At the moment, Western medicine and dentistry is all focused on how. How do I fix this? What do I prescribe? What do I do? What do I implant? How do I image? We need to find out what and why first. This is what we call healthcare. So for this, we need a health village. And it's mentioned it early on in the introduction. We need a team of people who can ask, answer, and also address the 5 WH questions. To quote the words of one of my very dear and most respected friends and colleagues, Dr. John Coyce, all of us know more than any of us. So let's have a look and see why the current medical system simply cannot handle this problem. The reasons are simple. It is overregulated by Medicare and insurance, with a strong input from lawyers, with litigation, with malpractice. There's limited time per consultation. It's in and out here in Australia at 7.38 minutes beginning to end for a consultation. It operates in isolation. It is the doctor behind the desk. There's no team. The role is to quickly diagnose, prescribe, and refer. There is no time to identify the cause. You've got a waiting room full of people there. It uses the across-the-desk approach where my job is to fix you. This is disease management. This is not healthcare. The dental setting is much better suited to this. What we're talking about is primarily a behavior disorder. We're looking at dysfunction, not disease. Dentist teams are in a better position to identify and educate. Because behavioral change is a team effort, it's not a solo effort of writing a prescription. This, my friends, is healthcare. This is not disease management. We need early awareness. We need to be able to interact with our patients and our friends and our family to educate them what to look for. The open mouth could be a warning sign. If this child continues to push on one side, he is going to develop postural imbalances. There is no question, there is no doubt in my mind that the heavy school bag on the one shoulder, these are the starting points of scoliosis and the other spinal deformations, which are not genetic. They are nurture, they are not nature. These are the epigenetic things that cause the shift from the genotype to the phenotype. And this requires a homely, friendly environment rather than a stern medical office. We have to look for the canaries in the coal mine. This is a typical scene on a Sunday morning on Bondi Beach. Hundreds and hundreds and hundreds of children with parents and coaches at this training. Amongst those parents were doctors and nurses and dentists and physiotherapists. Did anybody notice or comment on this group? 4 cute little girls. 3 out of 4 children between the ages of 5 and 12 have crooked teeth. What you are seeing is all too commonplace, to the point that it is now considered as being normal. This is anything but normal. So the current situation is that nearly 1 billion people worldwide have sleep apnea. This came from the International Sleep Conference by ResMed at the American Thoracic Society in 2018 in San Diego. It indicates that the prevalence is nearly 10 times greater than previous estimates. This is somewhat a scondo. And it's getting worse. It's not getting better. Despite spending billions of dollars, the problem is getting worse. There are no valid scientific metrics to address this issue. But there is a solution. And I've been involved in that solution for over 20 years. And this solution is evidence-based medicine, but it is not accepted nor implemented. So in perspective, if you look at those billion sufferers and you see that less than 10% are diagnosed, less than 50% of those are compliant, treating only the numbers is what they're doing. They're not treating the patient. There has been no change to the principle of positive airway pressure in 45 years. Oral appliances reposition the mandible. They don't fix the problem. So we're sitting here with a fundamentally flawed concept. The concept that sleep disorders breathing is incorrect. Functional daytime breathing will translate to functional nighttime breathing. Sleep is not the problem. People wake up because they can't breathe, not because they can't sleep. And you know, the contradictory thing here is that the 2 gold standards, CPAP and oral appliance therapy, are not sleep therapies. They are breathing interventions that have nothing to do with the process of sleep. So there is a simple solution. It requires a 180-degree turnaround. We have to think breathing disordered sleep as the problem. And I came up with this term 20 years ago, and it's caused a couple of raised eyebrows, I can tell you. We have to address the issue at its source and identify and treat dysfunctional daytime behavior. We want to pay more attention to the patient attached to the symptoms than to the symptoms attached to the patient. And this is not compatible with the existing medical model, as we saw a couple of slides ago. Sleep disordered breathing just does not make sense. The only time that the process of sleep would disorder breathing would be if the breathing was dysfunctional to begin with. Otherwise, nobody would ever sleep. Healthy people would go to sleep, and then the sleep would disorder their breathing. Guys, it doesn't make sense. Given that we're awake for 2/3 of our lives and trying to recover for 1/3, to me it made perfect sense that the dysfunction was caused during the day and aggravated at night, but it was manifest. So all of this has caused upper airway resistance. There's too much air per breath, too many breaths per minute, in and out through the mouth, over those cracked lips, irritating mucosal tissues. It's the congestion that's causing the obstruction. But this is reversible. This is not understood at all by the medical or dental profession, which is looking for hard facts. Notwithstanding this, many ENTs are prescribing steroids as part of their protocols. They're saying the tissues are inflamed, the mucosa is inflamed, take some steroids to calm down the inflammation. They're not saying, why are these tissues inflamed? And we opened an integrative education center, which is still there. Some of you might know these two. That's Barry in the purple shirt. On his left is Eyal Botzer from Tel Aviv in Israel. He's the tongue tie expert. And on the other side next to me is Gabor Herman from Budapest. He's an orthodontist, a very progressive one as well. And we ran so many courses over those years in so many disciplines. We trained literally hundreds and hundreds and hundreds of people through that center. It also became the East Coast MyoBrace facility. So there was plenty of activity and interaction all the way around. So we have to face facts. The system is broken. It's broken because it's primarily a bottom line, money-focused disease management business. And believe me, it's not worldwide. I'm not sure if you guys are aware of the statistic, but only 16% of the world's population of people use Western medicine. The other 84%, who do we have? We have India with Ayurveda, we have China with traditional Chinese medicine, we've got Japan, we've got all the other nations who use traditional medicine. Western medicine takes up a large part of our lives, but not on a worldwide basis. It's built on the premise of disease management and not health creation. It's too controlled by government, health insurance, and lawyers. It is prohibitively expensive. I've been in practice for over 60 years. I remember what it was like 60 years ago. It was simple. Doctors drove Morris thousands. They didn't drive Maseratis. We didn't have all this technology. And we've out-technologicized ourselves. And because everybody is so afraid of malpractice and being sued, everybody is ordering more tests and doing more imaging than they really need to do, just in case. It's a slave to technology. And research is untrustworthy. And I know that that's a big claim to make, and I'm going to back it up. Many claims in research are simply not true. And even after practices have been debunked, they are still used. Here is a slide that comes from the Mayo Clinic. It shows a decade of reversal with an analysis of 146 contradicted medical practices. These are things that were gold standard. These were things that you could bank. These were things that you were told, we have the research. And although there's weak evidence base for some practice, it gains acceptance largely through vocal support from these prominent advocates and faith that the mechanism of action is sound. And later on, future trials undermine the therapy, but removing the contradicted practice is so often so challenging. Mammograms, hormone replacement therapy, the prostate-specific antigen for prostate cancer, stents, the apnea-hypopnea index, the diagnosis of asthma, the benefit of myringotomies, arthroscopic knee surgery, C-reactive protein testing, BIS monitors for anesthesia. These things have all been debunked. So let's go and talk to our two friends in 1975, Bill Dement and Christian Guilleminault. They jointly created the concept of OSAS, obstructive sleep apnea syndrome. They came up over a couple of years with the apnea-hypopnea index, the AHI. Both acknowledged that the AHI was flawed in its concept because there were arbitrary measurements. They said, what is an apnea? And one said, what about cessation of breathing for 10 seconds? Yeah, okay. What about 9 seconds? What about 11 seconds? And then the question came, what is a hypopnea? Well, it's not a full apnea. So how much of an apnea is hypopnea? Yeah. What about 50%? Some labs use 50, some use 30, some use 60. There is no standard which remains the standard. It has no scientific validity. And there is continuing disquiet and confusion regarding diagnoses and symptoms of the gold standards. And this all came under question. More professionals were challenging the AHI. The European Journal of Sleep Research investigated the science behind the AHI. And I'm not going to read the whole thing. I'll give you the link if you want it, but right at the bottom it says, a critical appraisal of the extensive literature shows that both assumptions are invalid. This conclusion prompts a reconsideration of the role of the apnea-hypopnea index as the prime diagnostic metric of clinically relevant obstructive sleep apnea. It's not valid, but you know there's no alternative standard. So it's still being used as the standard. The excuse is there's nothing else. We don't have anything else. We're going to talk about the AHI. Okay, don't get me wrong. The AHI is useful to indicate change. If your first AHI is 96 and your second is 15, we know that there's a change, but it misses more than it picks up. And you know, maybe it was invalid from the start. Then comes the question of evidence-based medicine. I mean, this has become totally and utterly prostituted in terms of its understanding. In truth, it is the intersection of three individual processes. It's the clinician's skill and experience and the expertise. It's the patient satisfaction and the success of the outcome. And it's the best available published research. Where these three things intersect, that is evidence-based medicine. It's being dismissed as lacking any scientific validation because the medical community is focused on the purple ring. EBM is all about research. No, my friends, it is not. It is all about skill. It is all about observation. It is all about anecdotal reporting. It is all about outcome. So these four accepted diagnostic metrics are inaccurate. The AHI is debunked as being invalid. The BMI was never intended to be an individual metric, and we'll cover that in a moment. Evidence-based medicine has been perverted to mean research. And sleep-disordered breathing is a grab bag classification for any form of disrupted sleep. So with these TLAs, which are three-letter abbreviations, we've actually messed the entire system. Look at the BMI. It was explicitly stated this should not be used as an individual metric. It was designed as a population marker based on a 200-year-old numerical hack developed by Adolphe Quetelet, who was a Belgian statistician. But you see, because it's a three-letter abbreviation and it's a single number between 1 and 100 that comes from a mathematical formula, it carries an air of scientific authority. It is mathematical snake oil. But yes, again, it is useful to indicate change. It's not useful as a diagnostic measure. So look at the formula. Nothing like these three-letter abbreviations. AHI plus BMI equals SDB. No, it doesn't. The conclusions are erroneous, but they continue to be promulgated and perpetuated until they take on a life of their own. It is primarily not a sleep issue. So we keep on getting asked. I mean, I must have been asked thousands of times, where are the clinical trials? There is this fanatical compulsion not to believe anything unless it's been randomized, controlled, double-blinded, placebo-verified, peer-reviewed, Cochrane-validated, meta-analyzed. No trials? What do you mean there are no trials? That's ridiculous. How can this thing ever work if there are no trials? Well, and this comes from Mayo Clinic again. Recently, a project of the BMJ titled Clinical Evidence 81 completed a review of 3,000 medical practices, not doctors' offices, medical procedures. It found that slightly more than 1/3 are effective or likely to be effective. 15% are harmful or unlikely to be beneficial, or a trade-off between benefits and harms. And 50% are of unknown effectiveness. Investigation complements these data and suggests that a high percentage of all practices may ultimately be found to have no net benefits. Is it really that black and white? Is the absence of evidence evidence of absence? Does the lack of proof invalidate evidence? Does the existence of a paper prove validity? Are we not better off being roughly right than precisely wrong? And for those of you who are involved with sleep studies, look at the last page of every sleep study. Are the comments not almost exactly the same? A trial of CPAP is recommended for a week or two at a water pressure of 10 centimeters, blah, 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 and lose some weight and turn on your side and get another pillow. It's whistling in the dark. And you'll see that this, as we progress, becomes worse and worse. We have a challenge. Sisyphus had it easy. All he had to contend with was a rock. We have this amorphous mass of ego and dogma that we have to overcome. Best practice is now being challenged. And of course, everybody is resisting change. We don't want change. There's legal risk in admitting mistakes of the past. Academia protects ingrained positions and dogma. I spent 2 years as an academic in a university in Queensland, and everybody defers to these clinical trials as though they're the be-all and end-all of everything. There is a resistance to anything that is regarded as not being proper research. It ignores the tenets of evidence-based medicine. And this is what I call fogma, which is the confused state of actually seeing results after having stated repeatedly that these results are just not possible. So, my friends, we have a problem. And the problem is a modern acquired syndrome, which is known as CRS. What does CRS stand for? Craniorectal syndrome. It's a syndrome that affects the large majority of medical and dental institutions and practitioners, those who adhere to dogma and past knowledge, and refuse to acknowledge that the world is in fact round. They steadfastly dismiss as irrelevant anything that does not accord with their own narrow world and thinking. See also ego. This is how they spend their lives. And if this is their constant position, is it any wonder they don't see the light? They make assumptions, and assumptions are dangerous. Things are not always what they seem to be at first. we tend to form our first impressions and then look for confirmation bias. Sometimes we simply get it wrong. Yeah, that's a martini glass. So the reality is 2/3 of life is awake and surviving. 1/3 is attempting to recover. Sleep is a normal physiological function. It is not a disease that requires medical intervention. It is the diseases of disrupted sleep that need medical attention. And this is where a highly complex discipline, such as our medical system, is required. Sleep and airway are interlinked. So here you see three very powerful people. They are saying there is too much focus on testing. They are saying that treating the data and the numbers is not treating the patient. What percentage of patients are seen by the person who is reading the sleep data and making the diagnosis? It is minuscule. There is very, very poor compliance. There is a lack of interest in treating to success. Something has to change.
Probably, depending on how it's defined, about 10% of the American population has obstructive sleep apnea. This is a risk factor for hypertension, stroke, death, atrial fibrillation, car crash, and a lot of things that can affect not just the person who has it, but their bed partner or the person in the shotgun seat or oncoming lane. So it actually is a public health problem of some magnitude. The diagnosis and management of sleep apnea to this point has been, in my view, too complicated, too time-consuming, too expensive, too patient-unfriendly, too test-oriented, and not nearly enough follow-up chronic management-oriented. That is changing. It has to change. There is a professional organization that continues to insist that physicians who are board certified in sleep medicine be reimbursed for reading the sleep studies, which is where the money has traditionally been, and which I can tell you is not rocket science. The management, actually, the follow-up, the actual care of the patients has just been sort of willy-nilly, slipshod, not necessarily done by people who even understand what a sleep study means. As a result, the vast majority of people with sleep apnea remain undiagnosed. They don't want to bother with all this expensive testing, or maybe they have the test but they never even get any follow-up. And many people who are prescribed effective treatment don't use it, again because chronic use of any treatment requires ongoing encouragement, education, follow-up adjustment, and care, which has really not been a huge focus of professional organizations, which seem to be a little bit more focused on testing than on actually taking care of patients.
Experienced woman. So we have this tyranny of testing. When the diagnosis is not obvious, the test can be inaccurate. You have to have a sleep study. You have to measure a normal night's sleep. It's not possible for this to be a normal night's sleep. How accurate can the results be? A side sleeper becomes a back sleeper. The room is dark. The room is bright. There's no intrusion. There's monitoring. There's comfortable sleepwear. There's cables and effort bands. It's a home environment versus a clinical environment. It all ends up being about the numbers. So the second person that I showed you there is Dr. Eileen Rosen, who is the president, who was the president of the American Academy of Sleep Medicine. The last paragraph is the most important. The overall success rate and compliance with treatment is low, and the outcomes less than favorable. The reason given is the excessive focus on testing, and very little is being done in actual treatment of the problem. We're hampered by research. It's hindering process. It's doing all kinds of things that it should not be doing. There's no alternative approach. The focus is still on intervention after the event. The existing metrics are still being used and they're being defended in the face of being shot down. Not everything can be trialed using the same approach. So researchers come under the gun. There is no single research protocol. We're too complex to compare. Research validity is just suspect. Richard Horton, the editor-in-chief of The Lancet, said, much of the scientific literature, perhaps half, may simply be untrue. Afflicted by studies with small sample sizes, etc., etc. He said, science has taken a turn towards the darkness. John Ioannidis, who is very much to the fore with COVID, he is one of the leading researchers. He says there is increasing concern that most current published research findings are false. He goes on to say a whole lot of things, all about sample size, etc. But the principle is, this is false. We talk about Cochrane. Cochrane used to be, it was the be-all and end-all. It was the world's most prestigious scientific journal. One of its highest profile board members was sacked because he protested against the commercialization of Cochrane. They wanted to take money for comments. This is where transparency is going. So here are a couple of quick comments from the leaders in the United States. Richard Bogan is the medical director of SleepMed, chief medical officer of SleepMed, clinical professor of University of South Carolina, associate clinical professor at Medical University. In an interview with Sleep Diagnosis and Therapy Journal, the topic was excessive daytime sleepiness. This is November 2018. In thinking about this, the important message is for us to recognize individuals have some sort of impairment beyond the medical risk. Fantastic. He is seeing beyond the machine. However, there are FDA-approved drugs. There are drugs approved to treat persistent EDS in patients. There are some drugs that have been recently studied. We must have our eyes wide open for drugs now and in the future that can address the issue of persistent EDS. It's all about the drugs. This is all about the intervention. This is not to do with the prevention. Then, of course, we have National Sleep Foundation, July 28th, not even a year ago. The head is Dr. David White. He is a Harvard medical professor. He's a former president of the American Academy of Sleep Medicine. He is the CMO of a major manufacturer of sleep treatments, $2 billion a year in treatments. Look what he says. If the physician could determine exactly why each patient has OSA, therapy could be directed at the specific abnormality or abnormalities. Good, but it's not necessarily a treatment. It's a change to that behavior. But the sting is in the tail. This could open up a number of new treatments, individualized to the needs of the patient. We don't need more treatments. There has been no major change in the way sleep apnea is diagnosed for 45 years. The techniques are not new. The drive to identify patients has steadily increased. There's no evidence. There's suggested relationships. There are no completed randomized controlled trials which effectively demonstrate that the treatment of OSA yields improved outcomes. And it goes on, my friends, it goes on. No new therapies have been introduced. Devices are smaller, quieter, better humidified. They deliver pressure in novel ways. Oh, maybe you're going to have, a mask in your ear one of these days. But they do not function greatly differently from the 1980s. Masks are better. They may be responsible for modest gains. Appliances are proved. Then, of course, we come to these surgical procedures. And basically what he's saying is the only one that is relatively effective is double jaw surgery. There are new things on the market. It's always got to be things. It's Provent, exhalation back pressure. It's hypoglossal nerve stimulation. Companies going bankrupt. It's a negative airway pressure device. It's a KEEP-PAP, which is an on-demand device, still undergoing clinical trials. Surgically implantable devices, pharmacological approaches. None of these things work. This is all intervention. Remember what Maslow said. If all you have is a hammer, everything looks like a nail. And believe me, a lot of these nails are not appropriate. Many of them cause more damage than they do good. So the reality of the system, according to Keynes, is that wisdom teaches us it is better to fail conventionally than to succeed unconventionally. So we've come to the decade where we want to move on. Primary care physicians, 78% of them surveyed said they lack confidence in sleep. They have limited training. The courses are all intervention-based. They understand the importance, but they have time constraints. They recommend sleep studies. There are conflicting outcomes. There's patient resistance. Where do people go for help? The answer is they come to a new specialty, and that is a specialty in functional airway management, and that cannot be done by the medical profession. Symptoms are not diseases, they're warning signs. Problems are seen as symptoms. They're not the same thing. The general medical model cannot do this. What's the point in having more and more and more ambulances at the bottom of the cliff? Just put a fence around the cliff, and then you don't need the ambulances. It's time to look for alternatives. Comes the burning question, are dentists doctors? Well, of course they are doctors, but just not perceived as such, for a very simple reason. Medicine is a serious business. Dentistry is just tooth mechanics, nice friendly place with high fives. How could you guys possibly know anything as serious as medicine? This drives me insane, and this is what has driven me to create this new specialty. But you're going to have to change your image. Perception is reality. If it looks like a dental office, patient will expect to talk about teeth. Change the environment, prompt questions, have concise information available. Feature your practice as an integrative center. Train and dress your team to be airway aware and not just dental. So we have a problem here, the human condition. We gravitate naturally to what we know best. The longer we're in practice doing the same things, the more difficult it becomes to change. Our DNA is tough. Our dental DNA is even tougher, urging us to verge on the sides of caution. But it's time for a change. Life begins at the end of your comfort zone. It doesn't matter if you want to upset the status quo, or upset set routines, or uncertain, or fear of criticism, or fear of reaction, or not knowing what to believe. Be concerned about what you are going to do. And as Einstein said, the thing that gets in the way of my learning is my education. We can change that. That is what this whole program is about. That is what the next 8 months are going to be. An education into how we can look at things laterally. Dentists have it all. It's a team effort. You have the lot. You have the rooms. You have the space. For heaven's sake, you have the patient base. What percentage of dental patients actually have airway problems? Extraordinarily high. So this is now health care, not disease management. Friends, now is the opportunity to make a real difference. And according to Rabbi Hillel from 110 BC, if not you, who? If not now, when? Thank you. Bye, Danki. Siyabonga. Nkosi. Kela Boga. Nzam.